Yeah, so I'm the Associate Medical Director for our Substance Use Disorder program at Esperanza. Which we'll talk more about, but I wanted to talk, we're going to cover addiction, Esperanza's response to addiction, and the opioid epidemic in Philly in general, which is a lot for a small amount of time. So I'll just go really fast, and feel free to interrupt with questions or hold until the end. Does that sound okay? I've been told that you're mostly pre-med, med nursing students. Anybody in a different discipline than that?
A little bit of public health.
Okay, good. Yeah, that too. Yeah, a lot of this is in that category, so that works. So this is the core verse for our opioid program here at Esperanza, which I'm sure you're all familiar with, but I'll read it anyway. One day while he was teaching, Pharisees and teachers of the law were sitting nearby. They had come from every village of Galilee and Judea and from Jerusalem, and the power of the Lord was with him to heal. Just then some men came, carrying a paralyzed man on a bed. They were trying to bring him in and lay him before Jesus, but finding no way to bring him in because of the crowd, they went up on the roof and let him down with his bed through the tiles into the middle of the crowd in front of Jesus. When he saw their faith, he said, "Friend, your sins are forgiven you." Then the scribes and the Pharisees began to question, "Who is this who is speaking blasphemies? Who can forgive sins but God alone?" When Jesus perceived their questions, he answered them, "Why do you raise such questions in your hearts? Which is easier to say, 'Your sins are forgiven you,' or to say, 'Stand up and walk'? But so that you may know that the Son of Man has authority on earth to forgive sins." He said to the one who was paralyzed, "I say to you, stand up and take your bed and go to your home." Immediately he stood up before him, took what he had been lying on, and went to his home, glorifying God. Amazement seized all of them, and they glorified God and were filled with awe, saying, "We have seen strange things today." When I was 19, I moved to San Francisco and was doing outreach with homeless youth, many of whom were using heroin or addicted to alcohol, and a lot of whom were leaving foster care system. They'd age out of foster care or were away from foster care. And it was a time, and for me in my life, where I was fresh out of my bachelor's degree, didn't have a lot of life experience. I had literally no experience of illegal drugs. I never managed to go to a party in high school or even came across alcohol. So it was a deep dive into a world that I wasn't familiar with, and I think the good thing about feeling kind of over your head is it does make you cling to Jesus and to the teachings of Jesus a little more closely. And my mentors at the time taught me the reflection technique of using your imagination to imagine yourself as each one of the characters in one of the stories, and to just kind of gain from the story by doing that. And this was one of the verses that really spoke to me when I started to encounter addiction for the first time. Because I think that we can all resonate with being a paralyzed man, feeling helpless and blocked and without help. But I would hope that also that we are seeking to posture ourselves as the friends of the paralytic. And addiction, I think, if you think of this on the more metaphorical level, if you think about addiction is something that blocks us from relationship with Jesus, blocks us from relationship with each other, and blocks kind of fundamental aspects of how we're created to be. And it is so the way is blocked, and the way to Jesus is blocked. And so the SED team, our goal is to be the friends of the paralyzed, and our task is to bring them before Jesus. And the way is blocked, and so we need to find creative ways to get before Jesus. And sometimes that means tearing up the roof of what is the typical way of meeting Jesus, which is through our institutional churches or through more traditional means. And so that's our goal, is to be creative tearers up of the roof. I was going to ask you to again, but it's me. So in Philly, you've probably already come across the opioid epidemic. It's all around us. In 2017, fentanyl, which is a highly synthetic highly potent synthetic opioid hit Philly. We had a heroin issue before that. We're part of the I-95 corridor between DC and Baltimore, us, Boston, and New York City that has become kind of notorious for fentanyl opioids moving up and down it. And these stats are older, but it hasn't changed. In 2019, opioid overdose related causes, most of them were from 19134, which is where our Kensington clinic is. And then you can see the highest concentration included our other zip codes, which are the targets for Esperanza as well. And along with opioid and IV drug use, of course, comes hepatitis C and HIV incidents and fatal overdose, and that is the main thing. So 2017, fentanyl started to really take over heroin. Now we don't actually see much in the way of heroin. It's all fentanyl on the street. So this is all on the back of kind of the oxycodone overprescribing that was happening 90s, 80s, 90s. And so it was kind of this bad combination of new drugs like fentanyl coming out that are synthetic and are not reliant on the Golden Triangle to get into the country, and the overprescription of narcotics, and then us taking people off narcotics fairly abruptly and then transitioning to illicit drug use. And then we saw during the pandemic about a 30% increase in overdose deaths. So there you are, 9134. That's our number. So here's unintentional overdose deaths by specific drugs, and you can see the very precipitous rise in fentanyl here, the fall in heroin there, and I can say that in the last 2 years I have not seen any heroin in a urine drug screen. It's all been fentanyl. Of note, methamphetamines, which is green, traditionally has not been a big drug of addiction in Philly, but we've actually in the last couple of years seen a big, actually the last year, have seen a big spike in methamphetamine coming into the area. And cocaine, which is always been a little bit high, so there's our cocaine. You can see the cocaine kind of spiking up with the fentanyl. And frequently that's how we're seeing them in the clinic, as we see them mixed. So fentanyl, they have some great graphics on the internet that show like the relative strength of fentanyl to heroin. They're kind of terrifying because it's 100 times more stronger than morphine or heroin. Withdrawal starts sooner, lasts longer, and is more severe, and that's highly related to fentanyl and Suboxone are both lipophilic. So the mu-opioid agonist, or receptor, is the main receptor of opioid addiction. With stimulant addiction, which we'll talk about in a minute, it's multi types of receptors, and so that makes it harder to treat. But with opioids, it's the mu-opioid receptor that fentanyl bonds to, and is more, has a stronger bond to it, so higher affinity. And unlike heroin and morphine, it is lipophilic, so you store it in your fat cells. So what that means for us on the ground is that as that drug is leaving your body, just enough of it stays in your fat cells to make it very difficult for us to get you on to the buprenorphine. Talk more about the buprenorphine in a minute. So in terms of overdose risk, it's a higher overdose risk with a higher level of central nervous system depression, so lower respirations, lower heart rate, and tolerance goes up faster, and this extended terminal half-life has been the main barrier to actually getting people on to methadone, or methadone's a little easier, on Suboxone.
So when you mean extended terminal half-life, that's
that lipophilic. So yeah, so we'll see when we're looking at the metabolite in their urine, we'll see, even when we've successfully gotten them onto the buprenorphine, we'll see a norfentanyl metabolite lasts for weeks. So, but usually about 2 weeks. So in the old days of withdrawing people off of heroin, we used to think like it's going to be 8 hours to get that drug out of your system, and you're going to feel fluish for like another 3 or 4 days, and you're going to have anhedonia for another month. It's kind of the rough, like how's that going to go for you? But with fentanyl, it's about 2 weeks of withdrawal. So that's someone signing up to withdraw from fentanyl. It's you're like signing up for the flu. You're going to feel sick for a long time, and that's a massive barrier to actually getting people off of it, because that means you have to have a high level of motivation to get through that. Does that make sense? Yeah.
And that's just the initial, is just the initial part, and then there's
Yeah.
the anhedonia is just feeling like, well, you don't care about anything, just like
Flat and
Flat,
can't feel
like-
joy, and that's usually we expect that with any drug withdrawal, but particularly with opiates and benzos, and that also hurt your ability to stay off of that drug. If you're just feeling flat and can't feel happy naturally, then you'd be less likely to want to stay in that state. So what is on the street right now? Fentanyl. At the moment, about 90% of, and so the frequent thing when people are coming into us, they think they're taking one thing and their urine says that they're taking something else. So we always check their urine at their first visit, because then we can talk about what's actually in it. And the reason for that is that everything is mixed. So they might think they're buying fentanyl. Usually when you're buying fentanyl, you're buying it with cocaine. And but we're finding, like, you name it, there's everything is in everything. So frequently what they believe they're taking and what they're actually taking is not the same. So oxycodone, heroin, morphine, and methadone, the take-home methadone has escaped into the kind of the illicit drug population. Almost 90% of what they test off of those things has fentanyl in it. So even if people believe they're taking pills that are oxycodone pills, it's highly likely that they're not. And then benzodiazepines is a frequent thing that people mix with both of those, and almost always it's Xanax, but occasionally Ativan and Valium on the street. Xanax being the really evil one because it's so instantly reinforcing, so short acting. The other two, we actually use Valium, which is a little more longer acting to get people off of benzos on a slow taper. And then the main stimulants are PCP and cocaine, they've been around for a long time, and then meth is kind of the new player. K2, we had a surge of it. We're seeing less of it now. We don't have great testing for it, so you never know. There is a lot of illicit Suboxone on the street because people divert it. And then we have adulterants. So the main adulterant you're probably hearing about in the news for our fentanyl supply in Philly is a drug called xylazine. It's an alpha-2 adrenergic agonist, if you've taken your pharm class. So a little bit like a drug like clonidine or guanfacine that lowers your blood pressure.
chills you out.
Chills you out. Yeah, a lot of the news is saying like, oh, it's harder to reverse an overdose that involves xylazine. I have in fact not found that in some ways. It's odd, and we'll talk about reversing overdose, because in the old days, if you gave Narcan and they would kind of come roaring out with this surge of adrenaline, they would like sit straight up after being completely limp and gray, and once the Narcan hit, and now they don't actually wake up, they resume normal respirations and heart rate, pink up like you wouldn't believe, like you could tell when it's working, and then only a couple minutes later do they regain consciousness. And we think that that's the result of the xylazine, because we're not reversing the xylazine, we're only reversing the opiates. That's a rough rundown of what's out there. Yeah. Any questions on any of those? All right. So I think actually more helpful than knowing the physiological effects of addiction is understanding more its psychological characteristics. I think one of the things that's hard for families and friends to understand about someone, or for a person struggling with addiction to understand about why it is so hard to quit something and why people keep relapsing is that we have a poor understanding of how addiction works. So the first characteristic of addiction is tolerance. That is in fact a physiological that you get used to a dose of something, and I think it said in an earlier slide, fentanyl creates tolerance faster, so you need more and more fentanyl to get the same result. So a question people frequently ask me about using Suboxone as a replacement for opioids is, well, are they getting high off the Suboxone? And I never know how to answer that because most addicts are not getting high when they use anything. High being the feeling of euphoria. Because of the tolerance thing, they probably felt high the first time they used it, but it's very rare that they are taking it to feel well or okay. They're not taking it to, they use the word high, but they're not feeling euphoria. They're trying to feel normal.
To avoid withdrawal.
To avoid withdrawal, to not feel sick.
Right.
Yeah, they'll talk the dope, sick, and well, or frequently they'll tell that. They will say like, I need to get high, or but they are not in fact talking about the euphoric end of that. Most addicts don't feel, no addict feels that anymore. So yeah, so they do not feel that with Suboxone. So withdrawal symptoms is an initial stress reaction followed by a rebound reaction, and you think about the behaviors that go along with that. Oh my gosh, I don't have what I need, and so people will address very aggressive health-seeking behaviors to get what they feel that they need. We go for our front desk staff, and and then there's a rebound reaction where so that initial stress, anxiety, I'm anxious, I'm jittery, I feel jumpy, and then it is the opposite symptom of whatever that drug was giving you. So if you're addicted to caffeine, then your caffeine you use to solve headaches, you might get a headache, it's a withdrawal headache. You would feel more tired, less energetic, because the opposite of that is the caffeine's effect. You would pee less. What else would you have with caffeine? Well, it's something with vasodilation, but yeah, so does that make sense? So your rebound reaction is, so with opioid withdrawal, we think everything is gonna run, right? You're gonna have diarrhea, your nose is gonna run, your eyes are gonna be watery, people sneeze frequently, the opposite of what you would expect from like the cholinergic effects of an opioid. Self-deception, this quote I like, the exquisite inventiveness the mind can demonstrate in order to perpetuate addictive behaviors, denial, rationalization, displacement. We usually know that people are moving, and so a lot of the folks that we're treating with Suboxone in early recovery, so thinking about the first year or two of recovery, we see a lot of the externalizing of blame. Why did you relapse? What happened that you relapsed? Well, I relapsed because my wife was doing this and it annoyed me, and so then I just went out and used. And or on the flip side, they can't tell you why they relapsed. I don't know. It was Tuesday, and I just went and yeah. And then what we see over time is we see them kind of able to give you a little bit more insight into that, and they start to come away from this the rationalization and denial, which is all about lying to themselves, not about lying to you. And it goes more to like, oh, I was feeling really stressed out, I was feeling really anxious, I was feeling really lonely because of this incident. And then once they get that level of self-realization that how they were feeling, what they were doing, then we can start to work on coping behaviors other than using when that happens again. So you kind of just see this growth over time where they're kind of able to captivate that. I also think it's helpful to remember that they're lying when they are like that they're lying to themselves, not just you. The loss of willpower part, there's probably a better term for that. This is from an older book. It takes an average of 9 to 11 serious attempts to quit before someone is able to quit. And that, I think, is also encouraging when we have a failure and we think, well, that was maybe their attempt number 4, and well, hopefully they will survive and swing back for attempt number 5. So that is normal. And one of our, I think, kind of therapeutic goals in our groups and with our individual patients is also normalizing that, like, it is okay. It's not, the failure is not as important about what you're gonna do now, right? You're gonna get back on your Suboxone, are you gonna reach out to your supports, are you gonna come to group, or are you gonna go back to using daily? The relapse is not as nearly as important as what you do after that relapse. And then distortion of attention, also called the distortion of ultimate concern. I think one of the hardest things is to, when you see behavior that is like a mother abandoning their child to go get their drug of addiction, or doing these kind of unthinkable things, commercial sex work, stealing, lying from people that you care about, it's really hard to understand that behavior unless you kind of imagine, like, this is someone who is seeing the world, like if you're looking for a poster tube, that's the level of insight that they have on their world. They're moving through the world with very narrow vision, and I think that comes back to this, the distortion of ultimate concern. They can't prioritize, and I think where it hits us most spiritually is it kind of hits our most fundamental ability to love and receive love as human beings. Questions about that? I explained it. So the response to those characteristics of addiction, these are the 12 steps. This is a very, I want to say ancient, it's not that ancient, our older way of addressing addiction in our community was through a group called Alcoholics Anonymous, which is now branched out to Narcotics Anonymous. It has many forms. There's Al-Anon, which is for families who are dealing with addiction. And I think it is still at the core. It was a priest who I believe burnt out, and I don't know if he was an alcoholic, but he started it.
I know he's a believer, and I know he was an alcoholic.
Yeah, and
Bill W.
Yeah, and it was, and I think the wise thing he did was it's a community-sourced wisdom, so they have their red book and they have different resources that are all the pooled experience of many addicts, and the 12 steps are kind of their kind of core belief system, and you can see very much the Christian core in there, I think. In that it is about reconciling ourselves to God, ourselves, and the family around us, and to some extent the environment. So I think there's still a lot of wisdom to be learned from that, and we use we don't do 12-step meetings, but we do kind of a 12-step core, because our groups are more focused on our early relapse prevention. So at Esperanza, we have about 90, I think it was as of last week, 97 patients who are participating in our substance use program. That seems small, it's because it is, and we are extremely high touch. We see our patients at least weekly, some of them more than that. We have a high behavioral health component. Our kind of saying behind the scenes is Suboxone is not the therapy is the therapy, and so the Suboxone is giving them the space to do the work of recovery. We kind of live on this balance. The push right now on a federal level, which I think is wise, is a low barrier to care push. So we are surrounded by really excellent programs like Prevention Point that's down the road from us that will do a 1-month script of Suboxone and send you out the door, no other requirements. Because of who we are and because we were surrounded by so many great programs like that, we decided in thinking about how Esperanza was going to address addiction to provide high level of care for a few rather than go broad. I told my director, if we were in rural Kentucky and there was no other Suboxone provider for 200 miles around, I would make a different decision, but we're not. And so that's been, we are growing at the speed of our behavioral health staff's growth. Please send us anybody you know. So we have groups. I think a lot of you will probably end up shadowing them. So we do a group therapy 5 days a week. The bulk of our sessions are at the Kensington and Allegheny site because that's where the need has been. We have one group here and one group at Fifth Street. Our goal is to do intake within 48 hours of our first contact with them. Frequently we're able to do it the same day. We're actually low on primary care providers for sessions for the first time. This is 2 weeks ago was the first time we weren't able to schedule people within 48 hours, which is really rough. But generally, we schedule them on the same day, which means they can walk in. We're bilingual, Spanish and English. We offer group or individual therapy. Our groups are, a lot of people have negative experiences of enforced groups in prison with the Department of Human Services system, and so they're very kind of reticent to be in groups, and then once they are in the groups, they're extremely excited about it because they do things like art and yoga, and they really get to know each other and support each other. And in fact, when the pandemic hit, we closed our groups down and we just saw everybody as individuals, and they started meeting in the waiting room with each other in their groups, and we had to chase them out of the clinic. And then they found out that it was me who was making that decision, and then they were like following me around, being like, when did we start the group? So we did open our groups earlier than others did, partly because they really wanted it, and partly because we saw a big increase in overdose during the pandemic, and I think the isolation was part of that. But for some individuals, they're either not appropriate for the group, or the group is not appropriate for them, and so we do see them in individual therapy. We have intensive case management. We also have medical legal partnership. One of the biggest barriers to recovery is homelessness, and it's just crazy difficult if you're living on the street to stop using, and so we have a big push, food security and things like that, but really housing and safe housing is kind of a big push. And then our medical, we have lawyers that come and meet with them, and they'll work on custody. They do work on some expungement, but they also do things like food stamps and public benefits. We have a partnership with the dental team because, for a few reasons. If you have been in addiction, you're probably not seeing, up on all your dental care. So dental caries and abscesses are a big thing. But also, when you are stable on maintenance therapy like Suboxone, any medical treatment that would normally involve opioids becomes really complicated. So we have dentists that are really good at blocking pain in folks with high tolerance for pain that we wouldn't normally be able to block while they're on Suboxone. And then we have a prenatal partnership because the city started noticing that a lot of women who were addicted to fentanyl were going into labor, giving birth on the street because they weren't feeling the contractions. And so there's a big push by the city to not have that. We've had some bad birth outcomes, as you would expect from that. And so we have a partnership where they can walk women in for prenatal care with our prenatal team. And then at the K&E site, separate from our normal Code Blue procedures, we have a rapid response team which responds to overdose outside of our clinic. So we have security that walk our whole block. Have they been there yet?
Yes.
Okay, so we have that full.
No, they'll be there tomorrow morning.
So we own the whole block, most of it anyway. And so our security walks this quite wide perimeter, unlike here where it's just a parking lot. So they walk quite a wide perimeter, and you'll see there's a large amount of people using just outside our clinic. So our security has walkies that goes to walkies in our one of our hubs, and whatever team is in that hub is the rapid response team for the day, and they respond to overdose outside. I mean, any first aid, but it's almost always
And
overdose.
if you're at KNA and you see a medical assistant running, that's probably, and you didn't hear a close.
Otherwise, they don't run.
That's what they're doing.
They don't do, yeah, they don't, you won't hear the code. So if there's an emergency in the clinic, somebody,
have code blue.
there's
They
no
just have
notification
walkie. Their own
that's
walkie.
code blue, but if there's an overdose outside the clinic, it's a walkie to,
That they have,
just to the
so
one.
they can hear it, but.
Yeah.
So
So
if
if you
somebody
see a
sees
whole bunch of
somebody
people running
running
outside,
outside, then that's.
So they're not there on Sundays, is that right?
No, it's only the days, it's only when we're working.
I was driving by getting our dinner last night and someone had overdosed right in front of Esperanza and the police were there. I saw them actually putting the Narcan in and trying to wake him up and shake him.
It was good because for a long time the police did not have Narcan, which was just, and then they had the little glass vial.
Oh, that makes no sense.
I know. Yeah, so a quick rundown of medication-assisted treatment for opioid use disorder, which we've alluded to quite a bit. Methadone is a synthetic opioid that is nice because we can move people directly on to it. You don't have to detox off of fentanyl to go on to morphine. When I was first starting out working in addiction in the days of black tar heroin, a very high dose of methadone would have been 40 or 60 milligrams a day, and now it is very common to see people on 180 and 160, and that's kind of the strength of. So you go up to the level they are, and you gradually back down extremely slowly or not at all, and just keep them on it. The big issue with methadone in America is limited access, so there's only, I think, 12 or 14 clinics in Philadelphia. It has to be an addiction specialist, and it has to be, cannot currently be part of a clinic. It has to be a separate program under federal law to be a methadone program, standalone clinic, which is unfortunate. There is a law up to actually allow FQHCs to start prescribing methadone, which would be exciting. And then until the pandemic, it was also largely daily dosing, so the person has to go down to the methadone clinic. So already there's not a lot of sites, and they have to go there. If you were a drug dealer, what would you do? If you knew there was a methadone clinic, you target them. So they kind of, if you go to a methadone clinic in Philly, you walk a gauntlet of dealers offering you everything else, particularly benzos. So they end up being not very safe or accessible places. I lived in Australia, and their method of doing it was a local pharmacy. So like if I'm a methadone prescriber, I would prescribe somebody on methadone, and then they would register with their local pharmacy, and their local pharmacy would just dispense it to them every morning. And so it was extremely decentralized and a lot easier. So I hope we do that, but not yet. So we are left with buprenorphine, which is a partial agonist, meaning it imperfectly bonds with that mu receptor. It blocks it, but it doesn't completely stimulate that molecule. So the good part about that is it's extremely hard to overdose on buprenorphine because it there is a ceiling effect for those CNS depression, the respiratory and So if you give someone 32 milligrams of buprenorphine, or you give them 45, you're not going to see their heart rate and their respirations drop the more and more you give them. So that's a massive advantage because it makes it very hard to overdose on. The big risk for overdosing on bup is if you mix it with benzone. So hard to overdose on. It is also lipophilic, like fentanyl, and we actually use that, so your body is going to store it in your fat, and we use that to our advantage because it means that we can get a higher, it has an additive effect. So I can keep you on the same dose. For example, with the injectable form of it, which is Sublocade currently, we give them subsequent injections and they get a higher and higher serum concentration, and we are finding completely off books, there's not research on this yet, that after 2 or 3 Sublocade injections, it actually blockades the fentanyl and decreases the risk of overdose massively. There's not, I haven't seen evidence that says that out of our own clinic experience when people, so like an example of that was we had a patient whose mom gave her what she thought was a benzo, and her mom took one and she took one, and our patient did not feel an effect from it. She was on Sublocade, and her mom overdosed and lived. But yeah, so the Sublocade was blockaded the fentanyl. So I think you'll see in other countries they use buprenorphine for, you can imagine if you're doing surgery on a kid, maybe that post-nursing thing where their heart rate and their respirations are way low because they're opioid, they're opioid, and we have to reverse it or keep a close eye on them with buprenorphine. We could actually use buprenorphine post-op and decrease that risk quite a bit. Other countries are doing that right now. Buprenorphine is only approved for addiction treatment in the US, but I think you'll see it more in your practice as you go. It's available as film tablets as an injectable form. We do films in the injectable form. Nobody likes the tablet, and the injectable form has picked up in popularity a little bit quite because it's really nice because you don't have to think about whether you're going to relapse every day. You already had your injection and no longer is an option. So people really like the injection, even though it's one of the nastier injections. Did you end up seeing one?
Yes.
Yeah, oh, that's right, with me, yeah. Such a nasty injection. It is a sub-Q, thick, viscous, oily, like these big tough guys are really in pain. With this injection, it forms a nodule. It's, yeah. Good thing is there is a new one called Brixadi, which just got approved by the FDA and should be hitting the US in September, probably will hit our Medicaid formularies in like, I don't know, December-ish, which is supposedly a much nicer injection, which is, yeah. And then the other one that you'll hear about is naltrexone, related to naloxone. The brand name is Vivitrol, so you might hear people talk about that. Unfortunately, in the amounts that we're allowed to dose it, it is not strong enough for fentanyl. So it was a depot injection that you could use to theoretically block oxycodone, but in the world of fentanyl, it is not strong enough. There was a Columbia University professor who tried giving it weekly, and that worked, but insurance won't let us attempt that. So we largely don't use it, although we do use it for alcohol use disorder. We didn't talk about stimulants. Stimulants addiction is a big issue for us. And benzos, like the amount of prescribed benzos in this neighborhood is insanity. That was actually my first impression of Esperanza was, oh my gosh, every single patient is on benzo, not the kids.
Benzodiazepine.
Yeah, they're on Xanax. And so we do actually have a benzo taper protocol that we do with patients as well. There's something. Any questions on any of that? I'm going all sorts of out of order. Yeah.
Are there any other types of treatment to help with this kind of addiction? Like instead of medication stuff?
Is it a medication? Yeah. So the abstinence options, so which we utilize as well. My kind of thinking on it is developing, but I because we always have this like low barrier versus what's actually effective. So cognitive behavioral therapy you'll see mixed literature on the effectiveness for addiction, and that would be a whole like another discussion about that, but it does have evidence. So that's why we make the therapy the part of it. So your chances of recovering from this disease are pretty low, right? If this was type of cancer, this would not be a cancer that you want. And when we are treating an aggressive form of cancer, we throw everything at it. Have you ever seen anybody on one chemo drug? No.
Yeah.
We hit it from all sides. So our kind of thinking has been, we want to be excellent, because that's our goal, I think, as a clinic and everything. We want to be excellent in our practice, and we want to offer excellence to patients who can't normally access that. So kind of the tools in our arsenal here, so thinking about stimulants in particular, the evidence for what helps you get off a stimulant, there is very mixed evidence for some medications, topiramate, mirtazapine. The alcohol use is sort of very similar. The complicated thing with alcohol and stimulants is that it affects multiple receptors. The nice thing, if you're going to say that there's a nice thing with opioid addiction, is it really does just target the one. So we can target that one too and address it, whereas stimulants and alcohol target multiple receptors in our brain. I think particularly alcohol is crazy difficult to target with a medical therapy. So we get a little bit, with alcohol we use the naltrexone, we use the acamprosate, there's a cocktails of medications that we use, the evidence for all of them being pretty poor, evidence for all of them being better if you are already off the alcohol. So abstinence followed by medication to support you staying off of it for alcohol. For stimulants, the best evidence is for a period of abstinence, so enforced or otherwise. And so with our folks who are dealing with stimulant disorder, which is pretty common, they mix with their opioid use disorder. So it's pretty common that we stabilize someone on their opioid use disorder, which is by far the more deadly one, so that's worth doing. But they're still struggling with cocaine or methamphetamine. So then many debates among the team ensue about like what's the best thing to do for them. But what the evidence is getting them inpatient for a prolonged stay. That was before the pandemic quite a big, usually our Medicaid insurers would allow them to be like detox for 4 days and then they would release them. Since the pandemic, we're actually seeing that they're allowing for longer inpatient stays, up to 30 days. The old was 90, so we're still way short of adequate. So our kind of workaround for that is to go with private, non-insurer paid ones, so like some of the Christian ones. Drawback there is a lot of Christian ones don't allow us to maintain folks on Suboxone. So yeah, and your chances of surviving are better if you're on an opioid replacement therapy than if you're not. So we try to like do everything for, and then our other option in the city is something called intensive outpatient or a partial hospitalization model where they're going to a group daily or 3 times a week. We largely saw those fall off during the pandemic, so we're utilizing them a lot less because a lot of them went remote and just never came back. And we haven't found that to be terribly effective. Yeah, so that's, does that
Yes.
answer? Yeah.
Can you rehash how the methadone works? It's you kind of meet up to where they are and then you taper it down slowly. Is it more of a
Or you don't.
prescribed,
Yeah.
controlled pace?
Yeah.
Okay. And is that similar?
Well, so Suboxone, because of the partial agonist effect, it has higher affinity and bonds completely with the opioid receptor, so it competes with the opioid for that receptor. And the effect of that is that if you take buprenorphine while you have it in your symptom, you're going to feel withdrawals. It triggers a precipitated withdrawal. So they feel sick and they're more likely to relapse if they can't overcome that. With methadone, you don't have to do that because you're matching opioid to opioid, and so you just transfer them directly. The challenge is now we're all prescribing or at levels a heck of a lot higher than anyone was used to prescribing before. So I think the highest I've seen is a pregnant woman who was on 220 milligrams a day. That was her to feel normal. It's a massive amount. Like you wonder how she's conscious, but yeah. So yeah, makes you think like, is it like insulin resistant? Like it's ridiculous. Yeah. So it's much easier to get onto, but because of like if they gave me the choice of would you rather treat people with methadone or buprenorphine, methadone is a heck of a lot easier to get people onto because you don't have to detox them at all. but it is, all the limitations on it currently make it just not, we don't have any patients who wanna be on methadone because they know what's involved with getting it. I mean, if you think about, they're not even given, this is the time of your appointment, they're giving a 4-hour window when they have to be in the clinic, so holding on a job if you're on methadone is pretty much impossible. Yeah. Yeah, so the practicalities of methadone have made it not really useful. Yeah, hopefully that changes. Yeah, the massive advantage of buprenorphine is the ceiling effect, so they don't, the risk of overdose just, goes away. Any other questions? Yeah.
Is there a timeline for coming off buprenorphine?
That's an excellent question. No.
No.
So the data is that being on it for a minimum of 2 years greatly increases your risk of being able to stay off opioids in the long term. Some people will never be able to come off of it, and some people that is a good amount. Most folks want to be just done with it, and so the more frequently it's let's wait until everything else is a little more stable in your life before you come off of this.
So
You
the
want to be free of
the
it.
patient wants to get off.
The patient's like,
you're saying.
I've had 6 months, I'm ready, and we're like, where's your housing? Where are your relationships? What are your supports like? What's their, some of them are going through adolescence because they never did that because they were using, are they ready for that? And then we do extremely slow taper off. And usually what I do, if those are the folks on the film, is tell them to trim the film, trim a little bit off, and so you don't even feel the effect and go down slowly that way. Usually we do it when we know that they're stably off everything else. So if they're in the middle of a benzo taper, highly recommend you don't do your Suboxone taper. And a lot of people will never be able to be off of Suboxone. That's just the nature of how it has changed their brain chemistry or how their brain chemistry is developed. And that's okay. It's not something that's going to do harm to them.
So, yeah, we need to try it.
Yes. Okay, so you guys are gonna practice reversing overdose. A really nice thing is it's really easy. You just squirt. It's a nasal spray, not unlike Flonase, which is so much better than the whole glass vial we had to break. So naloxone is an opioid antagonist. Nobody calls it naloxone. We all call it Narcan, and it kicks the opioid off the receptors, reverses the respiratory drug depression, and they will come out of it. In the old days, come out roaring out of it and be really mad at you. Nowadays, not wake up because of this effect of this other drug, xylazine, and that's okay. So what you're looking for is not them regaining consciousness. To decide, so you're going to give it every 2 minutes, 2 or 3 minutes, which will be the longest 2 or 3 minutes of your life. So you really do want to time every 2 or 3 minutes until their respirations go back to a normal rate. And it is really weird, and their heart rate and respirations go zooming backwards really odd. They might not wake up immediately. Does that make sense? Yeah. You alternate nostrils. That's the one you're going to move, right?
Yeah.
Alternate nostrils just in case one nostril's blocked. 2 to 4 minutes to absorb it intranasally. It's also available IM, but even in the clinic we just use intranasal. The way to recognize if someone is overdose versus just really high is if they are not breathing. So you'll see people passed out on the side of the road, and if you were to go and give them a vigorous shake, they would respond to you. If they're responding, they're not overdosing yet. But you do not need to Narcan them. The ones who are overdosing are not breathing, and it's hard to miss because they are gray and clammy and ashy and does not look like someone who's doing well. And they do, the one big caveat is that can throw you off is they will do agonal breathing, kind of a gasping breath, but it's too slow. So if you're counting respirations, it's more around 4 than it is around that minimum 8 that we want. And so that is not a useful or adequate breathing pattern. So are you guys going to do rescue? Are you carrying little med bags?
Mm-hmm.
Okay,
Yeah.
so you want to bag off that person until they start fighting you and resume respirations normally. Was that?
We're gonna talk about rescue reading, we're probably not gonna advocate that they do it, but,
Okay.
yeah, because they're gonna be on the street.
Yeah, that's fine. So then, yeah, giving the Narcan, timing for the next Narcan, and calling 911. And I always say that, yeah, there may not be, and if bystanders do weird things, they've even had police, like, try to, like, step between one of our physicians who's actually trying to, like, do chest compressions, and bystanders do weird things, so you usually recommend it, because you guys are out in groups, yeah?
Mhm.
You know, one person respond to the person and someone else kind of like keep people away. Some of the bystanders are like case managers from prevention point who might come and do CPR with you, so that's great. But yeah, the crazy things happen. So yeah, so just make sure someone's watching kind of the scene for you. And when we go with our rapid response team, our security team does that. You see them, they stand back about 6 paces and they keep people away because yeah, odd things. So yeah, so in conclusion, we need to tear up the roof and find doorways for grace. This is one of my favorite books, Addiction and Grace, which is older than I am. Yeah. We need to recognize that the incompleteness within us, our personal insufficiency, does not make us unacceptable in God's eyes. Far from it, our incompleteness is the empty side of our longing for God and for love. It is what draws us toward God and one another. If we do not fill our minds with guilt and self-recriminations, we will recognize our incompleteness as a kind of spaciousness into which we can welcome the flow of grace. We can think of our inadequacies as terrible defects if we want and hate ourselves, but we can also think of them affirmatively as doorways through which the power of grace can enter our lives. Then we may begin to appreciate our inherent God-given lovableness. And I think in my now more than half my life working in addiction, I think the reason that I love it is because you really do see these doorways for grace open, and you do see people's lives change, and at the place that is so our capacity to love and our capacity to be known and to live shame free, like that's where addiction kind of wounds us, and also where the doorway for grace kind of opens.
Thanks, Sam.